All right, welcome to this explainer. Today, we are cracking the code on the beautiful, complex machinery of the human heart using the visual medical syllabus. We're going to start with a perfect baseline rhythm and then dive straight into the absolute chaos of cardiovascular emergencies. If you've ever stared at a squiggly line on an EKG and wondered what it actually means for your patient, you are in the exact right place. We're going to teach you how to read the heart purely graphically.
Here's our visual syllabus for today. We're going to hit 6 main topics: the conduction system, action potentials, atrial fibrillation, bradycardia and blocks, acute coronary syndromes, and we'll wrap up with electrolyte ECGs. Let's get right into it.
Section 1. The cardiac conduction system. Because, to understand a broken heart, we absolutely have to understand a healthy one first, starting with its internal electrical wiring.
Think of the heart as having its own built-in electrical grid. The impulse kicks off at the SA node, that's your natural pacemaker right at the top of the right atrium. From there, it travels down to the AV node. Now, this AV node is like a smart junction box. It actually pauses the signal for a split second. Why? So the atria can completely empty their blood into the ventricles. After that crucial delay, the signal just shoots down the bundle of His, splits into the left and right bundle branches, and races through the Purkinje fibers. The result? One massive, beautifully synchronized squeeze.
But what happens if that main pacemaker fails? Well, there's a brilliant failsafe built in, a pacemaker hierarchy based on a rule called overdrive suppression. Basically, whichever part of the heart fires fastest gets to drive the car. Normally, the SA node cruises at 60 to 100 beats per minute, so it's in charge. But if it breaks down, the AV node steps up. It's a lot slower, though, pacing at just 40 to 60 beats a minute. And if that fails, the His-Purkinje system kicks in as a last resort at a desperately slow 20 to 40 beats per minute. It keeps you alive, sure, but as you move down that chain, the pace becomes incredibly dangerous.
Moving on to Section 2, Action Potentials and Tachyarrhythmias. We're zooming way in now, right down to the microscopic cellular level, to see how these signals actually fire.
When you map the 5 phases of a single ventricular action potential directly onto an ECG tracing, it's honestly like a light bulb goes on. Phase 0 is that rapid electrical upstroke from sodium rushing into the cell, and boom, that's exactly what creates the QRS complex. But check out Phase 2. That plateau in the middle is driven by a slow, steady influx of calcium. And clinically, that cellular plateau creates the ST segment. If you can picture this graphical curve in your head, you basically have the blueprint for understanding how almost every antiarrhythmic drug works.
Speaking of drugs, when a patient's heart is racing in a tachyarrhythmia, you need a high-yield way to remember how to hit the brakes at the AV node. Just think of your ABCDs. A is for adenosine, B for beta blockers, C for calcium channel blockers, specifically the non-dihydropyridines like verapamil and diltiazem, and D is for digoxin. These are your absolute go-to pharmacological tools to slow down that AV nodal conduction. To keep all this pharmacology perfectly straight, we use the classic von Williams classification, which groups drugs by the exact ion channels they block. Class 1 drugs block sodium, which physically widens the QRS complex. Class 2 are your beta blockers, they just slow the overall heart rate down. Class 3 drugs like amiodarone target potassium channels, and that ends up prolonging the QT interval. Class 4 calcium channel blockers stretch out the PR interval. And finally, Class 5 agents like adenosine essentially cause a temporary roadblock right at the AV node. Section 3. Decoding atrial fibrillation. Okay, we're shifting gears from perfectly predictable action potentials straight into total electrical chaos.
When you look at an AFib tracing, notice what's missing between those spiky QRS complexes. There are absolutely no distinct P waves. Instead, the baseline is just this chaotic fibrillatory quiver. The timing between those tall R waves is completely unpredictable, which gives us that classic, textbook, irregularly irregular rhythm.
If you lock these core hallmarks into your brain, you're never going to miss an AFib diagnosis on the wards. Clinically, when you check their pulse, it'll feel irregularly irregular. On the ECG, 0 P waves and a quivering baseline. But here's a really cool physical exam pearl. Because the atria are just shaking instead of actively contracting, you won't see an A wave in the patient's jugular venous pressure, or JVP. It is just completely absent.
When it comes to treating AFib, rely on the high-yield RACE approach to keep things structured. R is for rate control, usually using a beta blocker or calcium channel blocker. A stands for anticoagulation, which is non-negotiable because you have to prevent blood clots from forming in that quivering atrium and causing a stroke. C is cardioversion, which can be chemical or electrical. And E is for electricity. Here's the golden rule, folks. If your patient is ever hemodynamically unstable, meaning their blood pressure is tanking or they have ischemic chest pain, immediate synchronized DC cardioversion is your very first move. Electricity cures instability.
All right, Section 4, bradycardia and heart blocks. Let's flip the script from a heart beating wildly out of control to one that is terrifyingly slow.
It's wild how a tiny electrical delay can completely snowball into a total communication breakdown. A first-degree block is just a stretched-out PR interval, usually totally benign. But then you get into second-degree blocks. Mobitz type 1, or Wenckebach, shows that PR interval getting longer and longer and longer until, bam, a beat drops. But Mobitz type 2 is where we enter the danger zone. The PR interval is fixed, but a beat suddenly drops without warning. This is an infernodal problem and can actually get worse if you give atropine. And finally, third-degree block. This is complete AV dissociation. The atria and the ventricles are completely divorced. They're beating totally independently of one another. That patient, they need a pacemaker right now.
Section 5. Acute coronary syndromes. So what actually happens when the blood supply to this intricate electrical system gets suddenly cut off?
Here's the thing about an acute myocardial infarction. It is not a static event. It evolves predictably on an ECG over time. In the first 30 minutes, you might literally only see these massive hyperacute T waves. But give it 30 minutes to 6 hours, and you get that terrifying convex ST elevation, the absolute classic hallmark of a STEMI. By 12 to 24 hours, pathological Q waves start showing up. Think of those as an electrical scar, a permanent sign of dead tissue. Eventually, over a few days, the T wave inverts. Knowing this timeline lets you determine exactly how long the patient's heart has been suffocating.
This is where the graphical magic really happens. You can use a standard 12-lead ECG like a map to pinpoint exactly which artery is blocked before you even step foot in the cath lab. ST elevation in leads V1 and V2, that is a septal infarct, pointing straight to the proximal LAD, the infamous widowmaker. V3 and V4 show you the anterior wall, also the LAD. Leads I, II, and AVF give you a window into the inferior wall, which is usually the right coronary artery. And the lateral leads, I, AVL, V5, and V6, point to the left circumflex. It is quite literally pure anatomical mapping, right there on the page. Once you spot that STEMI, you initiate the MONA-BC protocol to stabilize them. You give morphine for severe pain, which also drops their preload. You give oxygen, but strictly only if their saturation is actually below 94%. Then nitrates to further decrease preload, followed by your massive platelet blockers, aspirin, beta blockers, and clopidogrel. This standard cocktail basically buys you the precious time you need while you race them to the catheterization lab to open that blocked artery.
And finally, Section 6, ECGs and electrolyte disorders. We're going to look at how chemical imbalances in the blood can physically alter the heart's electrical footprint.
This one is a classic board question. Calcium levels have a direct, inverse relationship with the length of the QT interval. If calcium is too high, hypercalcemia, your QT interval shrinks down and gets dangerously short. On the flip side, hypocalcemia, or low calcium, stretches that QT interval way out. And that's bad news, because a prolonged QT puts the patient at extreme risk for deadly arrhythmias like Torsades de Pointes. Because calcium controls that phase 2 plateau we talked about earlier, its levels literally stretch or compress the ECG tracing.
And then there's potassium. When potassium levels climb above 5.5, the ECG goes through some incredibly dramatic changes. First, the T waves get really tall and peaked. Next, the QRS complex starts to widen out. If left untreated, that tracing devolves into this smooth, terrifying sine wave pattern right before cardiac arrest. In fact, hyperkalemia is notoriously called the syphilis of the ECG because it can mimic almost any bundle branch block or AV block out there. The takeaway? Always check the potassium.
Wow, we've covered some incredible ground today in this visual medical syllabus. We've built a foundation from single microscopic action potentials all the way up to full-blown cardiac arrest, using purely graphical representations to decode the heart's secrets. So my final question to you is this. The next time you're holding a 12-lead ECG in your hands, what hidden disease will you uncover? Thanks for joining me on this explainer. Keep studying those tracings, and I'll catch you in the next one.